Good morning and welcome to our Saturday Spotlight, a morning with Weill Cornell Medicine. My name is Daria Zingari, Scientific Director with OncLive, and I'd like to welcome you all here today. Throughout this pandemic, we have been showcasing various institutions and how they have been impacted and what they have done to continue to provide the highest level of care for their patients. Today, we are joined by faculty from Weill Cornell Medicine in New York City. I'd like to pause and give a thank you to our sponsors for the program today. So just to start off, we have a variety of topics that we'd like to cover. We'll be going over the COVID landscape, some coagulation complications that have arose from, with the COVID infection, treatment consideration in patients with cancer, testing for COVID, clinical trials, inpatient support of patients, with severe COVID. So we do encourage the submission of questions, which will be addressed in our Q&A portion at the end of the program. Here's our faculty for today. So I will hand it over to Dr. Manuel Hidalgo. He will be our moderator today for his introduction, and then he will be going through the program, introducing our speakers. Dr. Hidalgo?
Hello, and good morning, everyone, and thank you for taking the time to attend this meeting. I want to thank you, OncLive, for organizing this symposium, the faculty for the time today to share their knowledge, and of course all of you for attending the symposium. Needless to say, the significant impact of COVID in anything that is healthcare related. Today we're particularly interested in learning and discussing the impact of this pandemic in cancer care and in cancer patients, and we have a terrific outline of speakers to cover topics that are very pertinent to COVID disease itself, to complications that may be more frequent or severe in patients with cancer, talks that will address how to evaluate, treat patients who have cancer and happen to be also COVID positive, and to learn about the new strategies to treat this disease from an infectious diseases and critical care medicine perspective. It's very important that as we move forward in the next few weeks and few months, as we resume the care of patients with cancer, that some of them may have been sort of delayed or slowed down because of the fear of bringing them to our centers to receive care while the pandemic was at the peak, because they could get infected. How we transitioned to sort of a new normal where these patients can be brought back to our centers and can be treated effectively. I think that we will probably learn in the next few months that I think there is a significant impact on cancer patients because either they delay their care or because they didn't come to the clinic on time. I happen to actually be attending on the solid tumor service last weekend at NYP Weill Cornell, and I can tell you that I saw a few patients that came to us, called for care at a point that was a little bit late, and I think we are going to be facing that problem, and we really need to work together, to work as a team, to bring those patients back, and to make sure that they receive appropriate, effective, excellent care, and that we continue doing our role of cancer treatment and clinical research in the middle of this new normality, while protecting from COVID and other related complications. So these are some opening comments. I think we have a terrific panel of speakers today. There will be a Q&A session at the end of the day. And I hope you enjoy the talks and you have questions. And this is a dialogue, something for all of us to learn. Again, thank you very much, and look forward to an excellent symposium this morning.
Okay, so this is Monica Safford. I'm the first speaker after Manuel. I apologize if there's any hitches. This is a little bit new to me in terms of the software. So on my next slide, I have the disclaimers or the disclosures that you can read here. What I wanted to start with was just to sort of get to the beginning of the story, which we are now all too familiar with, where this novel coronavirus, we're moving forward very rapidly, and okay, here we go. That jumped from an animal to humans in all likelihood in Wuhan. And this open air market is where a lot of people think this jump may have occurred. In mid-December, the first signal was heard. And very quickly over the course of January and into February, it became clear that this was a virus that was going to spread all over the world. We watched with horror and trepidation what happened in northern Italy over the course of just a couple of weeks, where the healthcare system there was clearly overwhelmed. They ran out of intensive care unit space and had to set up MASH units, essentially, with intensive care units, ventilators. And despite all of these strategies, their system did get overwhelmed. And we looked at the reports online with growing consternation, because at the same time, this is what was happening in New York City. So this is a picture of a beautiful promenade that's out in front of the mayor's house, Carl Schurz Park, on March the 18th, which is when our colleagues in Italy were under duress. And we all knew that the virus was percolating and spreading in the community, and had some great consternation that our leaders in the state only closed down and recommended social distancing and people stay at home as late as they did. The results were frightening for many areas in the city. This is a curve that shows in the blue line the admissions to our 11 hospital healthcare system, and in the green line our discharges. So you can see that from mid-March moving forward, there was this very rapid rise in patients who were admitted. Late March to the first week of April is when we experienced our apex. Several of the hospitals in our health system, but also more hospitals around the city did become overwhelmed, much like what happened in northern Italy. And many patients could not be attended to and did not get ventilators that might have needed them. I think a really important observation in this curve is the green line, which represents our hospital discharges. So if you look at the first half of this slide on the left-hand side of the curve going up, you can see that there's quite a space between the blue line and the green line. And this created enormous challenges in our hospitals, because what this meant was that we were seeing more and more patients admitted with very few of them being discharged. And our intensive care units, if we hadn't done something very rapidly in the early parts of March with reconfiguring our hospital, we also would have been overwhelmed. So what did that look like? Hospitals all over the city began to completely reorganize within a matter of days. So for example, in our hospital, we doubled the number of intensive care unit beds really within a week. We finally got to peak capacity. It took us about 2 weeks, but the first step was to convert critical care units all over the hospital to just being medical intensive care unit. So the CCU, neurointensive care, any kind of intensive care unit was converted to a medical intensive care unit that very quickly filled up with COVID patients who were intubated. We also had to staff all those extra ICU beds, eventually spreading into the operating rooms, which I think is a strategy that many people use all over the country. Who is staffing that? So we also had to have a crash course from our pulmonary critical care team to train hospitalists, cardiologists, anesthesiologists, how to take care of these patients. We also had to accommodate a large number of redeployed physicians who were not necessarily used to taking care of COVID patients. They needed a crash course. So the reorganization and hospital preparedness is really a whole chapter unto itself. But I have to say, from our perspective, it went remarkably well. And there was a tremendous amount of cooperation and sort of a spirit of rolling up our sleeves and pitching in. And I think by most accounts, we feel that we really did a pretty good job. So we were the first group to describe what our COVID patients look like in New York City. And this is a letter that we published in the New England Journal of Medicine, and it compares people who required ventilation in the middle column to those who did not in the right-hand column. And there are a couple of things that are noteworthy. First of all, there is a slight age difference. There's also a gender difference. This preponderance of men getting into trouble is something that has been seen in several places, but not consistently around the world. We also noted that people with chronic lung disease, so current smokers, people with asthma, people with COPD, we were very worried that these were people who would get into big trouble, and they actually did not. So there was some surprise about who was getting into trouble and who was not. Obesity had been a signal. And that definitely was something that, I don't know why this is jumping back and forth, that we saw as well was a risk factor for requiring mechanical intubation. The curiosity is that hypertension and coronary heart disease did confer some risk, and that, to my knowledge, has not been well explained. So all kinds of things that that were surprises and head scratchers about these patients in this novel virus. So very quickly, our cancer physicians became very concerned because rightly so, many of our cancer patients, as Manuel said, had their treatment interrupted, but also were on immunosuppressive medications. And the concern was very real that they would be among the people who would have complications. So in our cohort of about 1,500 COVID patients that were admitted to our hospital, we only had 89 cancer patients. So that's remarkable in and of itself. They were about the same age. The race ethnicity breakdown is there. Of course, they had more comorbidities. That's to be expected. About 40% hematologic malignancies and 60% solid tumors. 40% did have chemo within 90 days of admission, but remarkably, their outcomes were similar to others. So this was sort of a tentative piece of good news, clearly not the end of the story. One of the things that we very quickly jumped on was attempting to help our frontline physicians with their clinical decision-making. So this is a decision tree that is designed to help physicians with just a few clinical parameters to identify who are the patients who are not going to do very well. So we had a phenomenon where some patients came into the emergency room. It was clear that they were critically ill, and they were either intubated in the emergency room or rushed to the intensive care unit. But there was a whole bunch of other people, the majority, in fact, who were admitted to the floor. And very quickly, our hospital medicine team asked for help because many of these patients were deteriorating extremely rapidly without the usual clinical warning signals. So they asked us, can you tell us who should we be particularly careful monitoring and who can we leave alone? Because we didn't have pulse oximetry, continuous pulse oximetry for everyone. So this exercise, which is under review, currently as a manuscript shows that people over here on this side of the decision tree, on the right side, are at very high risk for being intubated at 7 or 14 days, whereas the people on the other side are at very low risk. So this kind of an exercise, without going into a lot of detail, was very helpful in terms of our clinical decision making. So antibody positivity, now I showed you our curve, we're on the downside of the curve, so how many people were exposed? I think one of the amazing things about New York City is that it is really made up of neighborhoods. So what's true for New York is really not true for anyone. And you can see this here. I have the 5 boroughs. This is the percent of the population as of May 20th that seems to be positive for antibodies. And the Bronx is the winner here with 34%. So a third of the population of Bronx is antibody positive. About 30% of Brooklyn, about a quarter of Queens, but only about 20% of Manhattan and Staten Island. And you can see there's a fair amount of variability within each of the boroughs. And this is very much reflective of where the deaths occurred. So the Bronx is a little bit smaller than Brooklyn and Queens, and you can see that Bronx, Brooklyn, and Queens had a large amount of deaths, whereas Manhattan had relatively fewer, and Staten Island had the fewest. I think one of the things that it probably has contributed to the current civil unrest was the wide publicity that was rightly shed on who was contracting this virus and getting into trouble. And it was clear that it was our minority populations in the city. This is a wonderful paper, which is in press, from our gynecologic oncology group. The senior author is Ella Chapman. And she here has conceptualized, why did this happen? And I would urge you to read this paper. It's a really great synopsis of what I believe really describes why we had such disproportionate numbers. And here is the result. So if we look at our race, ethnicity, mortality, we see on the right-hand side of the slide, regardless of the age group, the preponderance of deaths in Latino and African Americans disproportionate to their proportion in the population. So I will hand it over at this point to the next speaker and look forward to your questions after we're finished.
Hi, good morning, everyone. This is Maria De Sancho. I'm the Clinical Director of Hematology, and I will talk about coagulation complications of COVID-19. As a hematologist, the 3 main aspects that we get called for in COVID-19 include COVID coagulopathy, the high risk of thrombosis in these patients, and how should we manage anticoagulation. COVID-19 can lead to systemic activation of coagulation and thrombotic complications. Early studies from China, already replicated in Europe and the United States, have reported that increased D-dimers, 0.5 milligrams per liter or above, were shown in approximately 46 to 63% of patients, mild thrombocytopenia in 12%, and mild prolongation of the prothrombin time in 5%. Moreover, patients who died of COVID-19 had higher D-dimers on admission and during the entire hospital stay. What is typical of COVID-19 coagulopathy? The most remarkable parameter is a marked elevation of the D-dimer, in some instances up to 6 times above the upper limit of normal, and this is associated with an increased mortality. Moreover, there is an increase in fibrinogen, mild prolonging of the prothrombin time, and mild thrombocytopenia or a normal platelet count. So the combination of an elevated fibrinogen, factor VIII, and von Willebrand factor parallel parameters of inflammation, such as ferritin, C-reactive protein, and interleukin-6, creating a severe inflammatory state. In contrast to typical DIC, In contrast to typical DIC, these patients have either normal platelet count or mild thrombocytopenia, prolongation of the prothrombin time, although mild, marked increase in fibrinogen and D-dimer. On the right-hand side of the slide, you could appreciate the plantar aspect of a foot on a patient with retiform purpura, and in the lower panel, the evidence of thrombosis inside a blood vessel. The pathogenesis of thrombosis in COVID-19 is quite complex. There is significant inflammation, and the inflammation actually drives the thrombosis. There are 4 major factors that accelerate thrombosis formation. One of them is that the severe inflammation induces a cytokine storm that activates the coagulation. The pro-inflammatory cytokines such as interleukin-1 beta, 1 alpha 6, and TNF stimulate the expression of tissue factor on the immune cells and initiate the coagulation through the extrinsic pathway. In addition to that, the fibrinolytic system is suppressed, and the reason for that is twice. One, there is an increase of plasminogen activator inhibitor type 1, and there is a decrease of urokinase type plasminogen. There is also activation of the platelets, and there is damage to the endothelium. So on the left part of the slide, we see an intact endothelium, which is an anticoagulant surface. On the right-hand side, the distorted endothelium becomes a procoagulant area because of the release of von Willebrand factor, factor VIII, as well as tissue factor. And this is remarkable in the bronchoalveolar capillary areas, as we have seen in autopsies of patients with COVID-19 in which there is marked microthrombosis as well as complement activation in the capillary of the lungs. In addition to that, hypoxia induces hypoxia-inducible factor, which also stimulates the production of tissue factor. Therefore, thrombosis in this condition is not a primary event, but is secondary to inflammation and hypoxia. In a study from China, also highlights that a marked elevation of D-dimer as well as prolongation of the PT are associated with bad outcomes. Here from Cornell as well as Lower Manhattan, in the first 393 patients, we can appreciate that patients on invasive mechanical ventilation had a higher D-dimer compared to patients who did not require invasive mechanical ventilation. And this also paralleled the inflammatory marker as ferritin, much higher in patients requiring invasive mechanical ventilation respect to the ones that did not. So thrombosis is also markedly increased in this viral infection. All sorts of thrombosis, including venous thromboembolism, so we see patients with DVT, pulmonary embolism, catheter-related thrombosis, atypical sites of thrombosis such as mesenteric or portal vein thrombosis. Moreover, there is also an increase of arterial thrombosis. Patients have strokes. Patients have also myocardial infarction. Very common to have thrombosis of the circuits for continuous renal replacement therapy, and definitely microvascular thrombosis in skin and the lung areas. What about venous thromboembolism in the ICU patients? Here there are 4 published studies, 3 of them retrospective, 1 prospective, but the bottom line is that the risk of getting the prevalence of a venous thromboembolism despite thromboprophylaxis is between 20 to 40%. Risk factors for this include an elevated D-dimer, lymphopenia in some of the studies, high fibrinogen, elevated factor A, von Willebrand factor, and in one of the studies, also the lupus anticoagulant was tested and was positive in 88% of patients. Another common problem that we as hematologists are being consulted is the presence of thrombosis in the catheters for dialysis. And here is a macroscopic view of the catheter in which there is caking on the intake and the outflow, and the microscopic evaluation of this thrombosis is basically mostly composed of platelets. Usually, a catheter like this is supposed to last approximately 3 days, but with these patients, approximately 50%, if there is no any type of anticoagulant provided, 50% of them last less than 24 hours. Here is another manifestation of thrombosis shown in the skin of a patient with livedoid reticularis. And here there is thrombosis of a blood vessel, and these 3 other panels show complement deposition, terminal complement deposition, C4D, and this is a normal part of the skin of the patient also with complement deposition. Here I cite 3 studies in which lupus anticoagulant was identified. The most remarkable one is the middle one from the UK, in which 216 patients were evaluated, and 20% of them had a baseline prolongation of the active partial thromboplastin time. Further evaluation of this abnormality revealed that 91% was due to the presence of a lupus anticoagulant. So how do we manage the anticoagulation on these patients? So a study from China also demonstrated that patients who were treated with anticoagulation, in this particular study, the dose was a prophylactic dose, the mortality was reduced compared to patients who did not receive any anticoagulant therapy. Based on this, there are 3 guidelines that have been already published. One is an international guideline, the ISTH, standing for International Society of Thrombosis and Hemostasis, the Anticoagulation Forum from the US, and NIH. Bottom line, all the guidelines recommend the administration of prophylactic anticoagulation in every patient who gets hospitalized with COVID-19 unless there is an absolute contraindication or if the platelet count is below 25,000 not due to DIC. The Anticoagulation Forum considers the possibility of escalating the doses of anticoagulant in patients who are critically ill. Based on this and our experience specifically from our intensive care colleagues, we made a decision early on to escalate the prophylactic dose initially for the ICU patients, but then as the wards became ICUs, this was also translated to the wards. And the dose that we chose is, we used enoxaparin as our low molecular weight heparin. The dose is 0.5 milligrams per kilogram every 12 hours when the creatinine clearance is equal or above 30, and once daily in the event that the creatinine clearance is less than 30 ml per minute. So similar in the patients who are in the intensive care unit. Fondaparinose is reserved for patients with heparin-induced thrombocytopenia. And a study published in the Journal of Cardiology from our colleagues at Mount Sinai of 2,773 patients with COVID-19 hospitalized. 395 of them were intubated, and this study showed that administration of therapeutic dose of anticoagulation reduced mortality from approximately 63% to 29%. There was 11 days increase in survival in patients receiving anticoagulation, and there was no major difference in bleeding between these 2 groups. So who should actually receive anticoagulation empirically? Treatment anticoagulation, treatment dose anticoagulation. We have 3 potential scenarios. One will be intubated patients who suddenly have deterioration of clinical and laboratory findings, and we think that they may have a pulmonary embolism, specifically when the X-ray or other markers of inflammation seem to be stable or improving. The second scenario will be patients with physical findings consistent with thrombosis, like, for example, the retiform purpura or peripheral ischemia or cyanosis, or thrombosis of the dialysis catheters. And the third scenario will be patients with respiratory failure, providing that we exclude the diagnosis of ARDS or fluid overload, specifically if the D-dimer rises sharply over a short period of time, and then the diagnosis of pulmonary embolism is highly suspicious. What about post-discharge prophylaxis? We know from previous studies that acute medical illness significantly increases the risk of venous thromboembolism up to 3 months post-hospital discharge. Therefore, these findings should be applicable for patients with COVID-19 infection, although data still is lacking. We should consider extended thromboprophylaxis after discharge in specific patients using already approved regimens. So we also have a guideline in our hospital. I want to emphasize that the importance of providing patients with education about symptoms and signs of venous thromboembolism, DVT, pulmonary embolism, and encourage mobilization at home, specifically after being in the hospital, some of them for more than 1 month. And then we do an evaluation about VTE risk factors, and if the score is 4 or above, and the patients have a low bleeding risk, then we provide prophylaxis with either oral anticoagulants, shown here, or in some instances, continuation of parenteral anticoagulation if we believe that the oral intake of the patient may be unreliable. So in summary, COVID-19 infection is associated with a coagulopathy that is distinct from disseminated intravascular coagulation. However, I would say that some patients, when they remain in the hospital for a prolonged period of time, of course, they get bacterial superinfections, they may get ventilator-associated pneumonia, and they may develop typical DIC. The coagulopathy is a marker of adverse outcome, and every patient who has COVID-19 and gets hospitalized should receive pharmacologic thromboprophylaxis unless there is a contraindication, and the critically ill patients, we should consider escalating the dose. Based on this, we have designed a randomized control trial, which is already available in clinicaltrials.gov. It's called the IMPACT trial, because it's intermediate dose versus treatment dose of anticoagulation in severely ill patients with COVID-19 infection. Thank you.
Great. Thank you, Dr. DeSancho. Now we'll move on to the treatment of cancer during COVID. We'll have Dr. Shah and Dr. Martin.
Terrific. Thanks so much. It's very nice to be here this morning. I'm Manish Shah, and I will be talking to you initially about the outpatient care of patients with cancer and COVID. And then my colleague, Dr. Martin, will talk about the inpatient care and some of the research that we've been doing, as well as billing. So I'll first talk about our process for adapting hematology and oncology clinical care in the epicenter of the COVID-19 pandemic. This slide was borrowed from Dr. Safford, and it kind of highlights what we experienced as a hospital system over the first 6 weeks of the infection. So the very first COVID-19 case came to our hospital on March 1st, 2020. And by April 8th, we had the peak deaths in New York at 779 cases. And we very quickly, much to Dr. Safford's credit, opened the Weill Cornell COVID registry, and we were able to track a lot of the aspects of the disease with regard to hospital admissions, readmissions, intubations, and that allowed us to improve our planning, I would say. So what we knew about cancer from the early onset or early time was very, very minimal data from China. This is one study that was early published by Liang and colleagues, and there were 18 hospitalized COVID-19 positive patients. 6 were diagnosed with cancer less than 2 years before the COVID-19 diagnosis. 4 had received chemotherapy or surgery in the previous month. And the suggestion from this very small cohort was that the COVID-19 cancer patients had a higher risk of severe events, in part because of older age, recent chemotherapy or surgery, and they seemed to have a higher deterioration. So that was the first idea, that perhaps cancer patients were doing more poorly. A separate study of 28 patients of 28 COVID-19 positive cancer patients from China suggested this, that a treatment within 14 days of getting the infection significantly worsened the likelihood of a severe event. And the severe event was ICU admission, intubation, or death. And you can see on the Kaplan-Meier curve that people who didn't get chemotherapy within 14 days were doing significantly better than patients who did. And that was highly significant with the p-value of 0.037. So with our initial reality as we were approaching the onslaught of COVID in New York was that our cases were very high. Cancer patients with COVID may have had a higher risk of contracting the disease, may have a high risk of intubation, ICU admission, and a higher risk of death. So, and then the other realities that we were living with or facing is that we weren't able to routinely test our patients, neither by PCR for an active infection or serology to see if they had a prior infection. And protective equipment was not always available as well. So we actually worked very diligently to change our practice with the following aims. We first and foremost wanted to make sure we took adequate and appropriate care for our cancer patients. And that meant that we potentially would defer or delay care for patients that could wait because we didn't want to expose them to higher risk, expose them to chemotherapy and give them worse outcomes. We wanted to minimize exposure to our healthcare staff, and we wanted to use our PPE wisely. So our leadership structure and communication strategy was as follows. We had daily leadership conferences, conference calls, and this functioned as a crisis cabinet. And here you see on the right, our division head, Dr. Hidalgo, and our service line head, Dr. Emlin. Dr. Emlin, Francie Emlin, is the person in charge of coordinating care between the college and the hospital. And then surrounding that are the service chiefs, fellowship director, infusion unit directors, and oncology administrators. So about 10 to 15 people were getting on this call on a daily basis, and weekly we would have a call with the large division. And we discussed many issues like new developments, guidelines for conserving PPE, testing, reallocation of resources, consolidation of treatment sites, and redeployment. So one of the key things is to reduce our clinical and staff footprint. So what that meant is that early on in March, at the end of March and early April, there was guidance from New York State to stay at home and to socially isolate. NYP is a large hospital system. It actually incorporates 11 hospitals across New York and the surrounding boroughs and over 40,000 employees. So that's an enormous clinical footprint. So what we did is to consolidate practices and work very diligently to try to minimize the number of patients and staff that would be able to, or that would need it to come into the city. And one of the key things was implementation of telemedicine. That's our video visits that we're now doing very commonly. So what we see here is in February, we only had 4 video visits as an entire practice. That's out of a total volume of 11,000 encounters for the month of February. And that's there were 2,700 infusions over the month of February as well. In March, you can see a dramatic rise up to 700 video visits that we were able to do. and our on-site volume went down by about 20%, 15%, and the total volume actually minimally changed. So we were able to take care of our cancer patients, but minimize the footprint. And that was just really over the last 2 weeks of March. Data from April and May are even more compelling. And we now think that about 30 to 40% of our practice in the future will be conducted by telemedicine or video visits. And that changes the landscape considerably. The other thing we did was we worked in teams to try to minimize exposure. And so let me explain this slide a little bit. So instead of an individual physician working with a advanced practice, facilitator, like an NP or PA, instead of a physician working with an NP or PA and then 2 chemotherapy nurses and a med tech and then sort of rotating days, we worked in teams. And so team A consisted of 2 physicians, an APP, and then the chemo nurse was, let's say, 2 of the 3 nurses and a med tech. And then they would work for a couple days and then be able to stay at home, and then the next team would pick up. And what that meant is that we kind of reduced our footprint by half just by doing that. We were able to still take care of all of our patients, but more importantly is that if anyone in Team A actually contacted the virus, they were actually not exposing Team B. So Team B would be able to come in and pick up the care for patients. So this reallocation of outpatient teams allowed us to significantly reduce our footprint. And then we also had to create new space, new areas. So one of the key things for cancer patients is that there are many patients who are asymptomatic, not infected. There are many patients who may have a cough or fever for completely unrelated reasons, but we wouldn't want to expose them to asymptomatic patients. And then there are some patients who are positive who needed urgent care. So we needed to create new patient units, a COVID positive unit, a unit that was at risk for COVID but not sure, and then COVID asymptomatic unit. And we were able to do that. And by doing this transformation, we actually were able to continue to service our cancer patients, continue to provide a safe work environment for our practice, continue to reduce the workforce footprint, and that allowed us for redeployment. So almost 20% of our faculty and staff were redeployed during this time to help cover the ICU unit as well. And then for the we actually, over the last month, were able to figure out how well we were doing. So what I'm showing you here is our COVID asymptomatic patients. These are patients that had no fever, no cough, no high-risk contacts. And over about a three-week period in May, we tested 475 patients, and only 5 patients were positive. These were asymptomatic carriers. And you heard earlier from Dr. Safford that the infection rate in New York was around 20 to 30%. These cancer patients who were really stringently following the guidelines and self-isolating, they only had a risk of 1%. So we think that our screening practices actually worked pretty well. The other part of this was the rule out COVID space. These were patients who had symptoms, and here 74 patients were seen, 21 were positive, so about a 30% rate of positivity. So it was smart to actually separate the rule out COVID patients from the asymptomatic patients. And then we found that our cancer patients had a positive serology rate of about 11 to 12%. So a little bit less than the general population, but significantly more than the patients that we were screening as negative. So I think overall, we were able to adapt our practices in a way to provide safe and adequate care for our cancer patients. I'm now handing it over to Dr. Martin.
Thanks, Manish. So I'll go over a little bit of what happened on the inpatient side. Our inpatient units in hematologic malignancies have historically been quite large. We have historically had 2 BMT services, an auto service and an allo service, 2 AML services, as well as a lymphoma service and a myeloma service. And historically, physicians covering those services also cross-covered outpatients in their own clinic And we generally followed hospital epidemiology recommendations regarding PPE during the COVID crisis, with the goal of minimizing, as Manish stated, with the goal of minimizing staffing and potential cross-exposure of staff. We collapsed those services to 3 services, and each of those staff that were there were dedicated solely to inpatient care, with no cross-covering of outpatient care during their period of time while they were on the inpatient service. Additionally, very early on, we required universal PPE, which included N95 masks for all patients, because we learned that many patients being admitted to the hospital early on, although they might not have had symptoms of COVID-19, they occasionally later on developed COVID-19. And because I think of those early transitions, we were able to minimize nosocomial spread. I think there was only one case that I'm aware of, an AML patient who probably had developed COVID-19 while in the hospital. Some of the things that allowed us to make these transitions included increased use of outpatient treatment facilities. So historically, patients that might have been admitted for IV treatment, for example, IV R-EPOC for diffuse large B-cell lymphoma. We transitioned to using the EPOC in the outpatient setting. We frequently transitioned IV therapies to oral therapies, so our myeloma patients receiving VDT PACE or even daratumumab in an outpatient setting were transitioned primarily to oral therapies. And we delayed non-urgent therapies, so myeloma patients, for example, may have had their auto transplant delayed. Older patients receiving therapy or being considered for therapy for low-risk MDS may have received transfusions for a little bit longer before starting hypomethylating agents. As Manish mentioned, one of the things that allowed us to do all of that included telehealth. And interestingly, that included telehealth on the inpatient side. One of the things that I think is maybe not entirely recognized in the whole context of this is the way the reason why telehealth was expanded so rapidly was because of an 1135 waiver related to the public health emergency that basically allowed all visits that would have typically taken place in the in-person setting could now be conducted via telehealth, which had to use audio and video telecommunications systems. And those were reimbursed at the same rate as in-person visits. And that applied both to office visits as well as hospital visits. That waiver is still in place now, but we expect it to be reimbursed at some point in time. Additionally, there were also increased reimbursements for telephone visits, although telephone visits are reimbursed significantly at a lower rate relative to video visits. So essentially what this meant on the inpatient side was that when we were called to do consults on patients suspected of having a heme malignancy or a non-malignant hematologic disorder, we could initiate the consult using a telehealth system with audio and video. Patients had iPads, for example, and we could talk to them that way and review their charts before seeing them in person. And this allowed us to minimize staffing and to minimize in-person contact. I'll just quickly go over some of the other changes or some of the other telehealth options that exist for physicians who are currently practicing. These have existed for a while. One are these virtual check-ins, which can take place between an MD or qualified health practitioner and a patient. These have to be outside the context of any other medical visit. Can't have occurred within 7 days of a prior medical visit, or it can't lead to another medical visit within 24 hours. And interestingly, there's no specific documentation required for these brief check-ins. And these even can include the use or sending of images. So on the outpatient side, I'm sure that everybody has had more frequent emails and phone calls from patients. Frequently, patients are sending us photographs of a rash. And now it appears that we're allowed to bill, not a significant amount, but you can even bill for reviewing a photograph that somebody sends you. These are the electronic visits that we've typically thought of with telehealth, and they are essentially what we've been doing in the past and what we're likely to do in the future. I think the challenge that we'll face as we continue to use telehealth going forward is that these electronic visits are not typically reimbursed at the same rate as face-to-face patient communication. So although I think telehealth is here to stay and probably should be here to stay, once the public health crisis is deemed to be over, the remuneration rates will change and go back to the way they were in the past, likely. Manish went over some of the early data with COVID-19 and cancer patients, and so I just wanted to briefly touch on that because it leads to some of the research that we're currently doing. This is a summary of 4 of the early Chinese studies that suggested that patients with COVID-19 and cancer had worse outcomes. And you can see that the numbers of cancer patients were quite small in the earliest studies, 18 patients, 12 patients, 28 patients. And the cancer patients were quite heterogeneous, and only the last one really used a matched control series. But still relatively small patient numbers, heterogeneous patients, and complicated results. After that, we started to see more studies from outside of China, and there the results were significantly more nuanced. Patient numbers were a little bit larger. Several of the first studies came from, actually all of the US studies came from New York, from Mount Sinai, from Montefiore, from Memorial Sloan Kettering, and as well one from Cornell that we'll go over briefly. And here we saw results that were significantly more nuanced. In the first study from Mount Sinai, there was no difference in mortality compared to non-cancer patients. This was done entirely based on electronic medical records. And there are confusing issues with that study. For example, they suggested that over the age 66, or between age 66 and 80, there was an increased risk of intubation, and only younger patients had an increased risk of mortality. In Mount Sinai, or in the Montefiore system, they had a significantly higher rate of nosocomial transmission, which likely represents something that Dr. Safford touched on, and that's that COVID-19 has shown us all that it is has the ability to separate those who have from those who have not. And even in a system like New York, we have hospital systems that are remarkably well-resourced. We're fortunate to work at a well-resourced hospital that made patient care and also staff protection a priority. Not every hospital has necessarily had the resources to do that, and unfortunately, some hospitals had higher rates of nosocomial transmission potentially because of that. Memorial Sloan Kettering initially found that there appeared to be an increased rate of, or an increased risk of mortality in patients who had undergone therapy with immune checkpoint inhibitors. However, in a follow-up study, looking at 69 patients with lung cancer, they confirmed that lung cancer patients have a high risk of mortality, but when controlled for smoking status, there was no association with anti-PD-1. We found at Cornell in a case control study we'll go over briefly that there was no difference in mortality compared to non-cancer patients. And the risk factors that we've all come to appreciate, age, male, sex, other comorbid conditions, appeared to explain the majority of the outcomes. Same results basically from France and from Italy as what we found as well. So this is a study that we conducted here. It was led by Gagan Brar from our GI oncology group in conjunction with several of our fellows who did a lot of excellent work to collect a lot of this data. It was a matched control study, case control study with 1 to 4, so so 89 patients with cancer and 356 patients without cancer. And the primary objective was to look at a composite outcome of ICU admission, intubation, or death. You can see here, well, it's a small slide, but I'll tell you that in general, patients were pretty well matched compared to between the cancer and non-cancer arms. And here, although again it's small, generally patients presented quite similarly. About 65% of patients presented with fever. Cough was a common presenting complaint. About a quarter, 20% to a quarter of patients, maybe it was 10% of patients, presented with GI distress. Oops. There were no significant differences in laboratory findings either when we looked at white blood cell count, fibrinogen count, D-dimers. But all of these things, I think, have all been recognized as predictors of potentially poor outcomes. As you can see, there was no difference in composite outcome of ICU admission, ventilation, or death when compared to the non-cancer population. And when looking at death alone, no significant difference. So we've found that cancer patients had a similar morbidity and mortality compared to non-cancer patients in patients when infected by COVID-19. And importantly, we did not find a significant association between recent cytotoxic chemotherapy or other immunosuppressive therapies. And patients in general presented pretty similarly to non-cancer patients. So there was a nice editorial published in Science recently, and that was that crises are no excuse for lowering our scientific standards. And I think that that is an important thing to keep in mind. There are a lot of observational studies. There was certainly I think, with good reason, there was a lot of rationale to try to publish a lot of data as early as possible to give an idea to the world of what might be coming. But we have to recognize that when those studies are done, particularly with small numbers, unmatched, no control, that they have limited ability to tell us what really is going on. As a lymphoma doctor, I recognize that there are 90 different kinds of lymphoma, and now we're talking about every kind of cancer. So we're talking about the person who's got chronic graft versus host disease following a transplant for AML, and we're lumping that in with the person with prostate cancer who's on hormonal therapy and had surgery 2 years ago. And those probably are not fair comparisons, but in all of these studies, they get lumped in together. And so I think we're more likely to have more valid outcomes in the future, particularly looking at histology-specific registries. And so there are registries in ASH and ASCO. There's another one from CC19, the Cancer and COVID Consortium. And I think it's probably a good idea for all of us to contribute all of our patients to all of these consortia and registries with hopes that we can learn more with more numbers. At Cornell, we continue to study our COVID-19 patients. Right now, we have a lot of data on our inpatients, but we're expanding that to all of our outpatients as well. And I think maybe more importantly, what we've realized is that the COVID-19 pandemic has had a major impact on cancer care, independent of COVID-19 infection status. We've all witnessed changes in diagnosis, changes in therapy, delays in therapy. And we have an opportunity to study some of that, not just on the Upper East Side, but also in Lower Manhattan, Queens, and Brooklyn with our 4 institutions. And I think that will potentially expand outside of, or give us some information about how patients are managed and look at a little bit of health outcome disparities, so we can potentially improve outcomes beyond the COVID-19 pandemic. Thank you very much.
Thank you, Dr. Martin, and thank you, Dr. Shah, for your presentation. We will look forward to any data that comes from Cornell. So moving on, next we will go over testing for COVID. We have Dr. Cushing, Professor of Pathology and Laboratory Medicine, Vice Chair of the Laboratory of Medicine, Director of the Clinical Laboratories, and Director of Transfusional Medicine at Cornell. Dr. Cushing.
Hi, good afternoon, everyone. Testing for COVID-19, there's so much to say, but only 15 minutes. So I'm sure you have been flooded with information like we all have from the newspapers, journal articles, with information about testing, and you're probably paying attention to our testing in the clinical labs more than you ever have, because there is misinformation and some subtleties and nuances. So I'm going to cover some of that today. So to start, testing can be very broad in COVID-19. It can include many types of tests: genetic testing, coagulation testing, proteomics or mass spec, cytokine assays. So I'm going to only cover today the most common SARS-CoV-2 specific tests. But even those type of tests have a broad range of applications, including acute diagnosis, evaluation of immunity in patients, screening of convalescent plasma donors, epidemiological or surveillance studies, and then a potential evaluation of vaccines, which will sort of be the next step. So I'll start with the diagnostic testing for SARS-CoV-2. So what do we mean when we say SARS-CoV-2 diagnostic testing? Generally, most commonly, we're saying that SARS-CoV-2 RNA or genetic material is present. And the testing that we most commonly refer to is real-time reverse transcription polymerase chain reaction, or RT-PCR, which amplifies SARS-CoV-2 RNA. And there are a number of different assays that target different genes for the virus, including the envelope, nucleocapsid, spike, RNA-dependent RNA polymerase, and ORF1 genes. And overall, the sensitivity of these assays is pretty similar. And so, you can have confidence in most of the assays that we have for RT-PCR. They're generally good across the board. We have reagent shortages in most of them. So generally, institutions have locked into one technology, but also had alternate backups for their RT-PCR testing as well. What they don't generally do is provide you information about whether the virus is alive or could be dead virus, or whether the virus is intact or in viral particles. So that's a weakness to keep in mind. There are also options that you hear about for point of care, and they're marketed to be rapid tests that are available near patient. And it's important to remember that these type of tests generally have lower sensitivity. And I'm going to highlight the two most common ones. There's the SARS-CoV-2 antigen test. So here we're looking at the protein expression or antigen expression, not viral genetic material, which is different than all the other diagnostic tests. And I have a couple of the most common ones listed here. And then the other thing that we generally see for point of care option is LAMP technology. And LAMP technology is nucleic acid amplification. LAMP stands for loop-mediated isothermal amplification. And that technology is has the one that you're seeing most commonly is the Abbott ID Now. The problem with these point of care options is that there's a pretty high false negative rate. The range has been reported to be between, in terms of agreement with other more sensitive tests, about 50 to 80% agreement. And so that could be a problem when you're worried about sensitivity. And generally, there has been a recommendation that if you get a negative test on either of these methods, that you should repeat it on an auxiliary platform. And that really limits their applicability to very certain, very specific settings. So I just want to mention this very nice graph that was published by Sitharaman et al. Last month in JAMA. It really nicely goes through what we're seeing for diagnosis for testing over time. And if you look at the figure on the left-hand side, you see this is on the very beginning, you see the exposure to SARS-CoV-2 virus. And what it's showing here is the blue line is the nasopharyngeal swab PCR, and then the pinkish purple line that almost or very closely almost overlaps it is bronchoalveolar lavage or sputum, so lower respiratory specimen PCR. And what this is showing is that those about by a week before symptom onset to about 4 to 6 weeks after symptom onset, you can detect PCR specimens. And in general, upper respiratory tract specimens like nasopharyngeal specimens or saliva are more sensitive early in infection. But for our seriously ill patients, there is a point where you can see that the level in upper respiratory tract is decreasing by around week 3 to 4, but you still have a fair amount of viral load for the lower respiratory tract. So that's important to remember in the very sick patients, that might be an ideal specimen later in the course of illness. What we're also seeing towards the dotted lines towards week 2 are the antibody tests. And these antibody tests, the IgG is the purple, and the IgG is the green, and the IgM is the purple. And you can see that they come up at about the same time, and they peak around week 3 or 21 days after symptom onset. So that's important to remember, because in the acute diagnostic period, they generally tend to be not that useful overall. We'll talk about that. And then the other important thing I wanted to highlight is the red line. And this is the time where you can isolate and grow virus from specimens from the respiratory tract. And why this is important is that viral culture is generally negative beyond 8 days, although we only have limited data there, but this is what we're initially seeing. So that probably means that the patients after 8 days are no longer infectious or potentially contagious. And you can see that the PCR is positive much, much longer than that. So that's kind of a problem that we need to address in our current testing. 2 other specimens to just mention. Fecal specimens remain positive the longest, but we're not sure that that's active replicating virus for the whole time. So in general, fecal specimens have not been used. And then saliva has generally been a promising specimen for diagnostic testing. And there's some controversy in the literature right now, but some institutions have had great success at using saliva. And of course, we like that because it's much easier to get a saliva specimen than it is to get an NP swab. So just important to remember that test results can be confounded by the stage of the disease, the performance of the test, the disease prevalence, which gives us our positive predictive value in a test, and the adequacy of sampling. We have in our institution seen a fair amount of what we think are false negatives for pre-analytic reasons, meaning that the specimen collection itself was probably not adequate, and repeated, we've had a negative turn to a positive. So moving on to serology tests, what do these tests mean? So it's important to think about the serology tests in terms of coronavirus and respiratory infections. We don't usually routinely use antibody tests for respiratory infections. You know, if you get a coronavirus or a common cold, you don't go to the doctor and say, oh, can you check to see if I made antibodies to, any certain coronavirus? We know that we have waning antibody response, and that most people can be reinfected even maybe within a year. So this is not an assay that we usually use. I think there's the most confusion about the antibody tests. And in general, when we ask important questions, antibody tests cannot give us the answer that we're looking for. So what do I mean by that? So what does an antibody test tell you? It basically tells you that an immune response to SARS-CoV-2 is present. So the type of tests that are looking at this are the ELISA tests, chemiluminescent assays, and lateral flow immunoassays, among a few other methods. They're detecting binding to a given antigen. They do not measure the function of the antibody. And the antigen that's present in the test is usually a recombinant protein, such as a whole spike protein, the nucleocapsid antigen, or a portion of the spike protein, like the receptor binding domain. And each assay has made a different choice about which antigen they want to use, and there are consequences to those choices. The nucleocapsid antigen, that's very immunogenic, and it tends to make a lot of antibody. So in terms of assay sensitivity, it's quite good. On the other hand, when you correlate with the more functional antibody assays that we'll talk about in a minute, like neutralizing antibody assays, the receptor binding domain antigen assays are usually have a better correlation. There's also a bunch of differences in what they're measuring in the assays. So some assays will just look to see, is there any IgG, IgM, or IgA, and those are generally called total antibody assays. And some are looking individually at the class of antibody that's present. They may only measure IgG. So there's been a lot in the lay press about the manufacture of these assays and the variable performance. And if you go onto the FDA website, you can see there are hundreds of assays now available, and the sensitivity and the specificity vary based on the different assays. The evaluation of the assays is clouded by a number of things: the difference in the sensitivity and the specificity, but also the time to obtain the serum sample post-symptom onset. You know, we all know from basic immunology, for a primary immune response, we don't expect an antibody test to become positive a day to 2 days after symptom onset, because your body has not had time to make the antibodies yet. And that's why it's very important to get the timing right for the antibody testing. So I just want to mention the neutralizing antibody assays for a minute, because there's a lot of discussion about these, and it's important that we understand what their role is. So what is a neutralizing antibody? So it's a test to detect virus-specific antibodies that are induced either through infection or through vaccination. And these antibodies have the ability to infection. And the level of neutralizing antibodies has really been used as the gold standard to evaluate the efficacy of vaccines to various viruses like influenza, polio, smallpox. And there are different types of neutralizing antibody assays. And I have a couple of them listed here, but the basic concept is that a patient's serum is mixed with virus and then either grown in wells and then measured, and then cytopathic effect is measured under a microscope. Or there's another type of assay called the CRRT, which is plaque reduction neutralization titer. And in this, the virus is combined with different dilutions of the patient's antibody and then is added to monolayers of cells. And then what's measured are the plaques of virus that are growing in those monolayers. And of course, if you have a significant amount of neutralizing antibodies, you'll have less plaques. So then you get the plaque reduction. So many of these assays are reported based on antibody titer. And so they can be very helpful in evaluating the function of the assay. However, we know that about 20% of individuals who are sick don't mount neutralizing antibodies. About 50 of them have low titer neutralizing antibodies and then there's a range of antibody titers that you can see. And then about less than 30% have high titer neutralizing antibodies. But what we don't know is how long these will endure and whether they're protective against future infection. So a lot of unknowns there. Just to cover a couple pros and cons of the different types of tests. In this table, the top two rows are looking at diagnostics, and I included the most common types of diagnostics that we see. And there's a difference between the point of care testing and the laboratory testing. Generally, point of care gives you a simple, inexpensive, rapid answer. And this can be as little as 30 minutes. I have an average here of 2 to 3 hours, but there are some that are available that are much shorter than that, but they have low sensitivity. The RT-PCR is highly sensitive and specific, but it requires a sophisticated, high complexity molecular lab that all hospitals don't have access to. In terms of serology testing or antibody testing, that's in the bottom two rows. We have the lateral flow immunoassay, which is point of care, can be available in about 15 to 20 minutes. And we have the laboratory immunoassays that we perform in our high complexity labs, and the turnaround time is closer to 1 to 3 hours there. The typical sample type for a serology assay is blood, most commonly serum or plasma, but it can also be whole blood as well. And then the strengths of a lateral flow is that it's rapidly available information and low sense, but on the other hand, there's low sensitivity and low throughput, meaning that we need a lot of resources to perform these. And we can't produce a lot of results at the same time. And then there's also potential for cross-reactivity with other viruses, which is a problem we have with our laboratory immunoassays as well. Our laboratory immunoassays tend to be a little bit higher sensitivity, higher throughput, and inexpensive. So how long does it take for the body to clear the virus? This is an important question for cohorting, isolation of patients, as well as for public health information. So in most parts, as I showed in the figure earlier, RT-PCR positivity tends to decline by week 3 and subsequently become indetectable. What we do know is that severe cases, it tends to persist longer, even to beyond 3 weeks, whereas mild cases will have usually a negative result by then. In some cases, viral RNA has been detected up to 6 weeks after the first positive test. But it's important to remember that the virus is generally isolated in culture only up through day 8 of the illness. There have been a few cases reported where we have a positive after 2 consecutive negative tests that are performed 24 hours apart. And interestingly, we have seen this in some of our oncology populations and other immunosuppressed populations. This is something that needs to be further investigated, whether this is a testing error or just a reactivation, and we weren't seeing full clearance, or we were at the level that's difficult for our RT-PCR test to detect. And then it's important to remember that although our assays most commonly give you an answer that says yes or no, if there is viral genetic material present, we don't currently report viral load or the presence of replicating virus. And both of those things are very important. And we are kind of making some progress there by looking at the CT values in our RT-PCR test, but they're not being routinely reported yet. So summary, testing sensitivity depends on the timing of sample collection, and that's true for both serology testing and for RT-PCR testing. And it's important in the early infection, look at upper respiratory, later in the infection, look at lower respiratory, and then serology testing is most accurate 21 days after onset of symptoms. For the FDA-approved point-of-care diagnostic tests and the lateral flow immunoassay serologic tests, they have lower sensitivity and are lower throughput. PCR test positivity does not always indicate infectivity, and positive serology does not equate with lifelong immunity, nor does it equate with impending recovery in acutely ill patient. And we're really learning a lot more about these topics as we go through this pandemic. Thank you.
Thank you, Dr. Cushing. That was very informative. And I know, testing is a hot topic these days. So we're looking forward to seeing progress made in that area. So we will turn it over now to Dr. Gulick. He will talk about COVID-19 treatment. He is the Rochelle Belfer Professor in Medicine, Chief of the Division of Infectious Diseases at Cornell Medicine. So Dr. Gulick.
Great. Thank you very much. Good afternoon, everybody. I have no financial disclosures to report. I will be discussing off-label or investigational use of products, specifically investigational agents, for the treatment of COVID-19. When we think about treatment of COVID-19, it is helpful to remember the clinical course of the disease as shown on this schematic. So someone's infected over on the left at the time of viral infection, and you can see that they remain asymptomatic for about 2 to 7 days prior to developing symptoms. During that time, the viral load in the upper airways is increasing and the lymphocyte count begins to decrease. After symptoms occur, it's about 1 week in a certain proportion of patients, they will go on to severe disease, most often characterized by respiratory complications, pneumonia, which can progress to respiratory failure requiring intubation. There are other target organs besides the lung, including the GI tract and cardiac muscle. And as we heard earlier, the inflammatory response in this stage of disease is a big component of what drives severe COVID into critical COVID. And this is accompanied by, as Dr. DeSancho reviewed, coagulation defects. Ultimately, some proportion of people who are intubated will go on to frank ARDS, and in a proportion of people that will progress to death over time. So when we think about treating COVID-19, we think about intervening at various points in the clinical course to try to stop or slow down or even reverse what's going on. The first step to come in with would be antiviral agents. SARS-CoV-2, of course, is a virus. And traditionally for respiratory viruses, we like to intervene early with antiviral agents. As the cytokine storm progresses, immunomodulators have been proposed either to interfere or abrogate the abnormal immune response that's occurring. In the late stages of disease, when ARDS occurs and tissue damage is occurring, this may be a separate place where agents that promote tissue repair might be of value. And of course, one question is, could we prevent this whole illness from happening in the first place? Are there strategies whereby if someone's exposed or in a high prevalence area of SARS-CoV-2, could we administer some form of prevention that could prevent this cascade of events? I'd like to refer you to the NIH COVID-19 treatment guidelines. The web address is at the top of this slide. I'm proud to be one of the co-chairs, along with my two co-chairs from the NIH, Cliff Lane and Henry Massour. These guidelines convene about 50 experts, multidisciplinary, from across the United States. We review all available literature and keep very up to date and propose treatment guidelines for the practicing physician. What do the guidelines say about early COVID disease? So the panel recommends no specific treatment for persons with suspected or confirmed asymptomatic or pre-symptomatic SARS-CoV-2 infection. And an A3 recommendation is strong recommendation, but based on expert opinion. And then the panel goes on to say there are insufficient data to recommend either for or against the use of any therapy, antiviral or immunomodulatory, in patients with mild COVID-19, and the guidelines currently say moderate COVID-19, although I'll show you some updated data that will throw that into question. So suffice it to say, today, in June of 2020, there are no FDA-approved treatments for COVID-19, and the current standard of care is supportive. That is oxygen, antipyretics, et cetera. We've come to appreciate that when people present with COVID respiratory disease, bacterial co-infections are quite rare. Although if people are intubated in the ICU, like other ICU patients, those become quite complicated and can be an important source of morbidity and mortality. What then are the candidate treatments for COVID-19? Well, as mentioned, antivirals, perhaps earliest in disease, immunomodulators, and then as Dr. DeSanto reviewed, antithrombotics, and in the late stages, tissue repair or cellular therapy. So what I'd like to do with the remainder of my talk is to review each of these classes of potential therapies. So antivirals. To think about how antivirals work, you need to understand the life cycle of SARS-CoV-2, which is shown for you in this schematic. So here's the virus over on the left. It is looking for its target receptor, which is the ACE2 receptor. It binds to that receptor, and then a protease is required in the very first step of the viral infection, which would be attachment to the cell, in most cases a respiratory epithelial cell. When the binding and the protease action occurs, the particle is internalized, fuses, and then endocytosed within the cytoplasm of the cell. In the second step of the life cycle, the viral membrane now uncoats and releases its contents, including copies of viral RNA, which are transcribed to other copies of viral RNA and also translated into viral proteins. The new copies of the viral RNA come into contact with the viral proteins, allowing assembly of new viral particles. And then these migrate to the surface of the cell and are released. And of course, many of these viral particles will be fully capable of repeating this cycle of replication in the next cell that they come into contact with. So the whole approach to antiviral therapy is to throw up roadblocks in this sequence of life cycle steps. There are three classes that are currently in development. The first are fusion inhibitors, which inhibit that very early step in the viral life cycle. There are a number of compounds that inhibit the RNA polymerase that transcribes viral RNA into RNA. And finally, a new class of agents are nuclear export inhibitors that interfere with the viral proteins being exported from the cellular nucleus. There is one drug that has been shown to have efficacy, clinical efficacy in COVID-19, and that's remdesivir. This remains an investigational antiviral agent. It is not FDA approved. It's in the class of RNA polymerase inhibitor, and it's a prodrug, and it's an adenine derivative. It has antiviral activity in vitro and animal models against the related coronavirus infections, SARS and MERS, and against SARS-CoV-2 itself. This compound is administered intravenously with a 200 milligram loading dose and then 100 milligrams a day for between 5 and 10 days. The compound was available, in fact, tested in a clinical trial for Ebola with over 500 individuals who received the compound. So there is a significant safety record even prior to the COVID pandemic. Clinical trials in COVID-19 have progressed rapidly. And if we could go back one, the first published data with this compound was in the New England Journal of Medicine, e-published in April, and that was a description of the compassionate use of remdesivir in 61 participants. However, this was an uncontrolled study of people with moderate and severe COVID-19, so really did not help us understand the efficacy, although reinforced the safety. The study that changed everything, and the first study and only current study to show efficacy in the clinical manifestations of COVID-19, was sponsored by the NIH and is called the ACT study. This was e-published in the New England Journal just a few weeks ago and enrolled over 1,000 patients across the country and the world with severe COVID-19, and I will review those results on the next slide. In response to the positive results from this study, the FDA released remdesivir under what's known as an emergency use authorization. That's a temporary program whereby an investigational drug that shows promise can be made available to treating physicians. And this was distributed throughout the United States. So here's the study that proved that remdesivir works clinically in COVID. Phase 3 multi-center randomized, double-blind, and placebo-controlled study, so very adequate design. The study population were adults who were hospitalized with COVID-19 with evidence of lower respiratory tract involvement, and as mentioned, over 1,000 patients were enrolled and randomized to receive either remdesivir at a dose, as mentioned, 200 and then 100 daily for 10 days, or a matching placebo. And the study endpoint was time to clinical recovery to discharge or the equivalent of discharge. And so what's shown for you here in figures taken right from the paper are the number of people who experienced clinical recovery. Remdesivir is in blue and placebo is in pink. And you can see numerically, remdesivir is associated with more people experiencing clinical recovery. And that reaches statistical significance because of the size of the study. You see the p-value there, highly significant at 0.001. Note, however, that people who got placebo also recovered quite a bit with COVID illness. And then the other way to look at this is to break down into individual groups. So this is a numerical system to classify how much oxygen people were getting. Class 4 was not receiving oxygen, 5 was receiving it, 6 was receiving high flow, and 7 was being mechanically ventilated, or ECMO. And what's shown for you here is how did they do, these subsets. You can see the top 3, the point estimates, all were on the side of remdesivir being better, that is associated with more clinical improvement. But note that the intubated patients, the point estimate is right at 1. So the significant benefit in that group is questioned. However, the overall conclusion is that remdesivir is superior to placebo in promoting clinical improvement. And that is now widely considered to be the standard of care for COVID-19 for hospitalized patients. Well, there's late-breaking news, and that is there was a parallel study, and we were a part of it at Cornell. We enrolled over 100 people on the study that looked at the duration of remdesivir, so randomized people between 5 and 10 days, and they concluded in this New England Journal publication just from about a week ago that for non-intubated patients, 5 days was not significantly different from 10 days. And then another component to this study was to look at people earlier in COVID infection, that is, people with moderate disease. So 584 people were with moderate disease, which they defined as an O2 saturation greater than 94% without oxygen, but with demonstrated pneumonia. And this was a 3-arm study, remdesivir 5 days, remdesivir 10 days, or the control arm standard of care. Now, this was an open label study, not placebo controlled, but this important standard of care led us to conclude what I'll show you in a minute. And that is that the clinical improvement was greater in the remdesivir 5-day arm versus the standard of care, the odds ratio 1.65, so 65% improvement in clinical endpoints compared with standard of care, and that reaches significance. Now, for reasons that aren't clear, the 10-day arm of remdesivir, although again favored in terms of clinical improvement, did not reach statistical significance. And I should quote the source here. This is a press release from the pharmaceutical company. These results have not been put together for publication just yet. However, they are informative. Safety-wise, there were no new signals. The remdesivir was as well tolerated as those who did not get it, and serious adverse events were actually numerically less in the remdesivir group. Another compound that you've heard a lot about is chloroquine and its cousin hydroxychloroquine. These are 2 FDA-approved treatments for malaria and autoimmune diseases, lupus and rheumatoid arthritis. However, they also have antiviral effects. They block viral entry, so they're examples of viral entry inhibitors, and have activity, each of them, against SARS-CoV-2 in vitro. Immunomodulatory effects are why they are used in autoimmune diseases, and so that's a potential benefit. There's been a large number of case reports, cohort studies, and small clinical trials with conflicting data as to the efficacy of either hydroxychloroquine or chloroquine for COVID-19, and some potential for cardiac toxicity due to QT prolongation. There are at least 3 large retrospective studies that found no benefit, one from the Veterans Administration, one from our colleagues uptown at Columbia, and one from New York State. And you can see that they literally looked at hundreds of patients. Now, it's really important to understand that these are retrospective studies. And so compared people who received hydroxychloroquine versus those who didn't, and in each case found no benefit. But the issue with retrospective studies, of course, is that it's difficult to control, and that people who were sicker may have been more likely to receive the hydroxychloroquine. And that was really shown in a very large, highly controversial study that was published in Lancet, a global study of over 14,000 patients that came to the conclusion that hydroxychloroquine not only was not effective, but was associated with mortality. Now, if you've been following the news this week, you will know that this study was actually retracted by the authors because they would not let the data be peer-reviewed by an outside group. So really almost a scandal in the field. So we really don't know if hydroxychloroquine works or not. There's a prospective study, many of them in place right now, and one planned at Cornell. And then the third type of agent is this interesting drug, which you will be familiar with from the world of oncology, selinexor. So this is an FDA-approved drug for refractory myeloma, has a large patient safety record and known side effects. But other properties of this drug are that it's an investigational antiviral and immunomodulatory drug. And it's an example of a compound that exports viral ribonuclear protein transport. So it has a new name, a novel selective inhibitor of nuclear export, or SINE compound. It's active in vitro and animal studies against respiratory viruses like influenza and RSV, and is now in a clinical trial that we are a part of at Weill Cornell. So no early data, but actively enrolling. The next group of compounds are antibodies, and there's been a lot of interest in antibodies, as Dr. Cushing just reviewed. Convalescent plasma, so the strategy of taking plasma from people who have recovered from an illness and then using that plasma to treat people with the illness. This has been used in H1N1 flu, that's so-called swine flu, and in the original SARS and MERS, the Middle East Respiratory Syndrome, and Ebola. There are potential risks of giving convalescent plasma, antibody-dependent enhancement of infection, transfusion-related acute lung injury, TACO, transfusion-associated circulatory overload, and allergic reactions. The initial reports were basically 10 or fewer patients published in major journals, uncontrolled in people with COVID-19 who got convalescent plasma. So really descriptive reports. But then a very large study came out in preprint form. This is the Mayo Clinic-sponsored compassionate use program for using convalescent plasma, and they reported their experience with 5,000 patients. However, important to know that this study was not controlled, so we have no sense of the efficacy of convalescent plasma. However, serious adverse events on this study were very low, and you can see very low numbers of any of the potential side effects or toxicities. So we are conducting, and others are, randomized studies. We have put in place a protocol at Weill Cornell to identify people who have recovered from COVID-19 so they could donate their plasma. And over 1,000 people have been screened online, and we've had over 30 donors so far. And we just initiated a multi-center randomized controlled study of convalescent plasma in coordination with the Canadian group. And this is for hospitalized people with COVID receiving supplemental oxygen. They'll be randomized either to receive convalescent plasma or not. And the endpoint is intubation and death at 30 days. We're actively enrolling. Other antibody approaches are proposed: IVIG, non-specific for SARS-CoV-2, COVID-19 hyperimmune globulin, and as alluded to by Dr. Cushing, COVID-19 broadly neutralizing antibodies, which could be used therapeutically. All of these are either in progress or planned. What about the cytokine storm? So immunomodulators to interfere with the cytokine storm. As we're aware, this is a very concerning part of COVID-19 and can lead to respiratory failure, multiple end organ damage, and ultimately death. So there are a lot of immune modulators that have been proposed. Probably the farthest along are the interleukin-6 antagonists. Sarilumab is in a phase 2/3 placebo-controlled study. Again, a press release in late April on the first 200 plus participants showed that there was apparently decreased mortality at the higher dose of sarilumab compared with placebo. And they altered the study on the recommendation of the Data Safety Monitoring Board, stopping the lower dose arm, and that study continues in progress. Siltuximab is an alternative, phase 2 in progress, and tocilizumab, a drug familiar to you all from CAR T-cell therapy cytokine storm, has also been tried in COVID-19, though remains unproven. And then there are a host of other approaches which are being studied, but we really don't have definitive data. And certainly it's safe to say that none of these have yet proven effective in COVID-19. And those include interleukin-1 antagonists like anakinra and canakinumab, BTK inhibitors, acalabrutinib and ibrutinib, and JAK inhibitors like baricitinib and ruxolitinib. Although scanning down this list, you can see there's a lot of interest in testing these agents in the cytokine storm induced by SARS-CoV-2 infection. And that leads us to the last part, tissue repair. So people who've been intubated, which can often be prolonged for weeks, are there cellular therapies that could be of benefit to help them repair respiratory epithelial damage? And there are stem cell projects that are in progress right now. So cellular therapies either at the pilot stage or phase 1 with phase 2 plans, and early information is just beginning to come out about this approach. So I've taken you all the way from pre-symptomatic through mild disease, where antivirals may benefit, to moderate disease and severe disease, and then ultimately critical disease and tissue failure. So I'll stop there, and thanks.
Thank you, Dr. Gulick. That was very informative. And being that my background is a pharmacist, I'm very interested in all the drug therapies that are being studied. So interested to see how those trials play out and if we come up with, something to use for this. So we will move on to our final topic, which is going to be inpatient support of patients with severe COVID-19. We have Dr. David Berlin. He is the Division of Pulmonary and Critical Care Medicine and the Medical Director of Critical Care Services. So welcome, Dr. Berlin.
Thanks for having me. I have nothing to disclose. I'm going to talk for just a few minutes about severe manifestations of severe COVID-19. The most important manifestations of severe COVID-19 are respiratory failure as well as thrombosis. And you can see that they're on radiographs, chest x-ray, CT scanning, and ultrasound. There are signs of ground glass opacities and areas of consolidation, and these often accompany severe respiratory failure, both with hypoxemia and with hypercapnia. And as you've heard from Dr. DeSancho, thrombosis is also a major problem in severe COVID-19, including cerebrovascular strokes, as well as DVT and pulmonary emboli, as well as areas of microvascular thrombosis we've seen in the skin and potentially also in other organs. And so I'm going to discuss for just a little bit then the supportive care or the care of patients with severe COVID-19. The first thing, of course, to remember is that for inpatients, it is absolutely essential to follow appropriate infection control. The good news about severe COVID-19 is that once we're using good and strict infection control practices, we really have had very little nosocomial spread to other patients within the hospital, as well as to medical staff. So we feel confident now in that once patients have been appropriately identified as having severe COVID-19, that they can be cared for using infection control practices, including contact, droplet, and airborne precautions. The overwhelming majority of patients with severe COVID-19 develop hypoxemia, and it is important to measure oxygen saturation and to supplement oxygen as need be. This can be done at home in patients with less severe disease, as well as in the hospital for patients with more severe disease. Initially, many patients, and we'll talk a little bit more about oxygen support. Well, I'll just keep going now with oxygen support since we're short of time. There's some information that patients can have improvement in oxygen saturation if they assume the prone positioning, lying in prone position as opposed to supine or upright positioning. That potentially improves ventilation and perfusion matching and can improve oxygenation. The data for this, it comes from studies of patients with mild ARDS, unrelated to COVID. There's a small series suggesting this, and then some uncontrolled series in patients with severe COVID that there's an improvement in the oxygen saturation. It can be very difficult to manage the airway in patients who are in prone positions, so we feel strongly that this should not be used in patients who are at risk of decompensating rapidly and requiring airway management. Another key feature of severe COVID-19 is volume depletion. And so patients who present with volume depletions due to fever and tachypnea, huge insensible losses through respiration, require volume resuscitation. And this is worth mentioning because there's a lot of the guidelines for severe COVID-19 recommend doing a volume neutral approach. And where that comes from is that previous studies of non-COVID related ARDS found that patients on mechanical ventilation did better when they had a even fluid balance goals as appeared to a volume resuscitated or excessively volume resuscitated fluid balance goal. Those studies, which were done pre-COVID, were all in patients who'd been volume resuscitated for many days. So what those studies really show is that once patients have been in the hospital and adequately resuscitated and are now on mechanical ventilation for a couple of days, at that point, it's very important to avoid fluid overload. but certainly up to that point, all patients who are volume depleted based on the history and physical examination and laboratory studies should get adequate volume resuscitation. We don't want to over-resuscitate them, but we certainly don't want to leave them under-resuscitated and at risk for hypoperfusion and kidney failure. So we're going to fix the volume deficit, and once the volume deficit is fixed, we're going to shoot for a more even fluid balance. You already heard about the importance of thromboprophylaxis. Another key feature of managing patients with severe COVID-19 is knowing what type of advanced ventilator support to use. So for patients who are becoming more and more hypoxemic, an option to use is called high-flow nasal cannula, whereas the oxygen can be delivered by not just, say, 5 or 6 liters a minute, but you can give up to 40 or 50 liters a minute of oxygen flow. High-flow nasal cannula is a bit controversial because of the concern that it creates aerosols, which contain virus, potentially infectious viruses. So there's a concern about using high-flow nasal cannula and its risk of infection to healthcare workers and other patients. And there's an idea that we should be using N95 respirators and potentially having patients in single room and even negative pressure rooms when they are on these devices. More and more throughout this epidemic, there's been a push to use more and more high-flow nasal cannula, and we've been incorporating that in the later stages of the pandemic. So we give high-flow nasal cannula, adequate supplemental oxygen, but a key detail to know, a key feature of the decision-making for caring for patients with severe COVID-19 is to know when they require intubation, And the decision to intubate, of course, is one of the most consequential decisions in caring for any patient. But patients who are having progressive respiratory failure, who have signs of confusion, mental status changes, for patients who have excessive or unsustainable work of breathing, for patients who are becoming hemodynamically unstable, all of those patients require emergency endotracheal intubation. And we don't want to wait until the last possible moment, because at that point, intubation can become impossible to perform, and it can result in profound hypoxemia, shock, and cardiac arrest. So we don't want to wait until the absolute last moment to perform endotracheal intubation. We're going to use our traditional intubation criteria for COVID-19 as we do for any other disease. We don't want to intubate too soon in people who can get by without it, but we certainly don't want to wait and allow the person to arrest in the hope of staving off intubation. So we have to use our usual clinical criteria. There's been a lot of talk in the media and press and social media about avoiding intubation because of the high mortality rate, and we think this is somewhat unfortunate. There were some early publications that quoted astounding mortality on patients with mechanical ventilation. We think those were unfortunate publications. Most of those publications did not wait to see what happened to the patients who were in the hospital before making the claim about the mortality rate. So one of the most important publications that was erroneous was in JAMA. They cited a 90% mortality rate of older patients who are on mechanical ventilation, but was important to recognize, and a correction was issued subsequently, that 3/4 of the patients in that cohort were still in the hospital at the time that the 90% mortality rate was claimed. And this is really unfortunate. I've spoken to many friends and family members around the country who've told me that they were told not to allow intubation because of the absolute chance of dying if the person got intubated. We believe this is not true, and that we should use our usual intubation criteria for deciding whether or not to intubate people. Once people are intubated, there are a couple of things that can be done to ensure that the patients are well cared for. One is that it's absolutely essential to measure the patient's height to determine the predicted body weight to figure out the size of the tidal volume to be administered. So even if you're not a pulmonary critical care doctor, you want to be sure that your patient gets the correct height measured and that the dose of mechanical ventilation, the dose of tidal volume, is titrated to your patient's height. Just as we wouldn't give a medication or chemotherapy to a patient without measuring their correct weight or body surface area, we want to do the same thing for mechanical ventilation and measure people's height. And once we have their height, we can get their predicted body weight, and then we can use a tidal volume that's appropriate for them, generally less than 8 mLs per kilo of ideal body weight. So if you have patients who wind up on mechanical ventilation, you really want to find out and make sure that you're using the appropriate tidal volumes, which is 8 mLs per kilo by predicted body weight or less. And then once we are on mechanical ventilation, we want to use some positive end expiratory pressure to prevent atelectasis, and we want to prevent lung overdistension by keeping the plateau pressure less than 30 centimeters of water. So 30 centimeters of water pressure or less in patients who are on mechanical ventilation, along with a tidal volume of 8 mLs per kilo or less, and that defines lung protective ventilation. Some of those things might need to be changed for people who have central obesity. They probably can tolerate higher plateau pressures, but these are the two key features to performing lung protective ventilation, which is proven to prevent mortality in all forms of ARDS, and we think is absolutely essential to perform in COVID-19. There's a lot of stuff in social media and in the press about COVID-19 not being ARDS. There are now a number of large series that have been published at Cornell, New York Presbyterian, Columbia Presbyterian, the Mass General, all have published large series of many hundreds of patients on mechanical ventilation. And we know that the respiratory mechanics of these patients and gas exchange disturbances are very typical of ARDS. We also have autopsy series to show that patients' lung disease includes the pathological hallmark of ARDS, which is diffuse alveolar damage. So all of those things point to the fact that COVID-19 causes the syndrome of ARDS. Of course, ARDS is a heterogeneous syndrome, and COVID is no different than any other disease in that it's a heterogeneous disease, and we don't have exact ways to manage people that we know are specific for COVID-19 yet, but certainly the basics of ARDS management, which is limiting lung overdistension, using enough PEEP to improve compliance of the respiratory system and oxygenation are essential. So those are the key features. We're going to give oxygen. We're going to follow people carefully to see when they need intubation. We're going to fluid resuscitate them until they're euvolemic. We're going to give them DVT prophylaxis. And once people are intubated, we're going to do a general lung protective strategy with some PEEP. And we're not going to base decisions on whether or not to intubate on some claim about that everyone with COVID-19 dies on mechanical ventilation. We know that to not be true. For example, the Mass General published their experience from March. And in March, their patients who had been intubated, 2/3 of those people survived and left the hospital. So we're not going to assume that every person who is on, who needs intubation is going to die once they get intubation. And since we're short on time, I'm going to stop there and allow time for questions.
Thank you, Dr. Berlin. That was great. So we will now open the floor up to questions. Dr. Hidalgo, if you would like to read the questions off and direct them to our panel. So Dr. Hidalgo, I'll hand it over to you. No. Okay, so in the absence of Dr. Hidalgo, I will read the questions off. So this one came in when we had Dr. Safford speaking, or Dr. Cushing may be able to answer this. So how did you conduct the antibody test, blood or saliva?
So this is Manish. I can answer that. I think that this was with regard to our testing our asymptomatic patients. So the 475 patients that we tested, these were tested by a mucosal swab, a nasal swab. The serology was done by blood. So that's how the testing was done.
Great, thank you, Dr. Shah. And now this one is for Dr. DeSancho. So do we have any data from patients in Italy or China who were discharged after successfully overcoming COVID-19 and placed on oral anticoagulants to treat their pulmonary embolism, and how did they do?
I don't have any data from China or from Italy. I can tell you for the patients that we have here, if they have a suspicion of a pulmonary embolism, and we continue anticoagulation for a total of 3 months.
Okay, thank you. Okay, so this would be a general question. So let's see. Or our hematologist on the panel, so Dr. Shah or Dr. Martin. Have you seen a higher incidence of patients presenting with persistent cough thinking that it is COVID, where in normal circumstances they may have thought it was an allergies or a cold, but it ends up being a cancer diagnosis? So have you encountered that in your practice?
Yeah, I guess I can take that. So, COVID, we focused a lot on how COVID affected us as an oncology practice, but we're preparing for patients. One thing that didn't come out as much, I think, is that this affected cancer patients as well significantly. They, Dr. Hidalgo mentioned this at the very beginning, where they may have avoided coming into the hospital or coming into a high risk area because of fear of getting the infection. Similarly, the symptoms of COVID, so having a fever or having a cough, is quite prevalent in oncology practices. And so we have had patients who have come in with symptoms that would be typical of an infection, and then were found to be COVID positive, and vice versa. People who swore they had COVID, they had a high-risk exposure, but they came in and they didn't have that. They had some complication of their cancer treatment.
Thank you, Dr. Shah. Our next question.
Can I just add?
Yeah, sure. Dr. Martin.
I'll add to that as well. We did have one patient in the hospital who was repeatedly tested for COVID negative, and only after a very clever resident looked into more depth, they were found to actually have an aggressive Burkitt lymphoma with no lymph nodes anywhere, but with extensive bone marrow involvement. And so I think COVID-19 was just so prevalent in our thinking that it occasionally did distract us, I think, from thinking about other kinds of things that could be going on. And I think we learned from that case that, COVID-19 is out there, but everything else is still out there as well.
Thank you, Dr. Martin. So we have another question, and this is for Dr. Cushing. So Dr. Cushing, we have a question. Is there any data or value to measuring circulating C5 levels for hospitalized patients to determine high risk for thrombosis?
Yeah, that's a great question. In general, measuring complement is not something that most hospitals have easy access to. They tend to be more in reference labs and less high throughput assays that most hospitals have available to. That is something that we are researching here at Cornell, along with Dr. DeSancho. So probably more to come on that, and its specific role as a biomarker, or also potentially as if we start using other treatments that are C5 inhibitors, that could be another use for that. So probably more to come, but interesting question.
Thank you, Dr. Cushing. And we have another question from, so I would direct this to Dr. Gulick. So is there any promise in the trial that's looking at colchicine as an immunomodulator? So has there been any enrollment there for patients?
I'm aware that people thought about colchicine among many, many compounds that have been proposed as immunomodulators, but I don't think there's early results on that. I think the study's in progress.
Okay, great. Okay, well, that seems to be all of our questions for today. Thank you to our panel for joining us. This has been very insightful. We thank you to our audience for joining us today on this Saturday morning, now afternoon. You will receive a link to watch this webinar shortly following. Again, you can visit onclive.com to sign up for any of our other additional webinars that are upcoming. We have a couple on CAR-T and hepatocellular carcinoma. So if you have interest in those, please go to onclive.com. Thank you, and have a wonderful rest of your weekend.
Thank you.
Thank you.